a Gates or a Allen bar. Allen bar is nothing but a very low, it comes from dense ply, a long shank bar which is the shank is flexible but very difficult to procure. The last batch what I had was some of my students sending it to me from Gulf. Okay, now we probably resort to more of your Gates. Okay, so this is where I have done the access. Okay, so we can do it little more quickly when compared to the conventional method. Okay, the canal was accessed, and then because for the fear of instrument separation, I wanted the student to go do the cleaning and shaping only with a hand instrument here. We didn't go for overzealous enlargement of the root canal, and then that's the post-op X-ray. That's as conservative as what you can get. Okay. Of course, if you had noticed, okay, one thing what I didn't mention to you is we are going in for usually access for the central is done on the palatal side, but here we have done it from the incisal axis because that gives you the straight line axis. Okay, just not to confuse you, we probably some of these access opening guidelines have been remained unchanged for a very long period of time, and those were the days when we didn't have the aeroter, so we had only ultra slow speed. Some of the senior people will definitely know it's very difficult to do the cutting, and probably it was designed for that. But the chances for you to identify the root canal is much higher in the center of the tooth. We don't want to deviate too much. So incisal opening, access opening is much more ideal for all these obliterated anterior cases. Okay. In fact, probably to tell you the fact that we have all started doing the access much more towards the incisal even for routine cases, because that's where the straight line access is there for the root canal. Okay, fine. So for if you're not still agreeing to my point there, probably for all these obliterated root canals, try shifting your access towards the incisor. That's just the message what I wanted to convey here. Okay, and then this guided access, if you look at it, even an non-experienced, inexperienced operator is able to do the procedure safely. Okay, there are a lot of evidences in the literature, because most of the times you just cannot wait for the specialist to come and do the access opening. Okay, fine. So far so good. Fine. Is it heavy dose on the morning, Sunday morning? No? Fine. You want me to pause it, or shall I just go and finish? Probably I just have 15-20 slides more. That's it. Okay. So let me just go and address the last thing what I wanted to, management of separated instrument. Okay. So there are two things here. Okay. So if you ask us, our postgraduates, ma'am will agree, the biggest thing what a postgraduate fears is to come and tell me that it's a separated instrument there. Okay, we'll come to what happens, because you know that it can compromise the outcome. I'll discuss it in the next slide. But for me, there is one more biggest problem. Can anyone tell me? What's the biggest difficulty apart from managing this case? There's one more biggest difficulty what you all feel. Super. Legally telling the patient that we have separated an instrument, and that too if you are having you're supposed to be experienced enough, and the patient has come with some confidence to you, if you are not going to tell, that's the biggest nightmare even for me. Okay, being an endodontist or a specialist, of course I should admit that the last time when I broke is more than probably a couple of years later, because I take all the precautions so that I will not break it. Still I can't be 100% sure, you know, because of the anatomic challenge what you have. But I feel I could not get some legal opinion, but I feel it's definitely must that we have to inform the patient. Forget whether the patient is going to sue you or shout at us, or probably going to take the money back or not going to pay us money, that's different. But it is, we are legally bound to inform the patient that there is a separated instrument. So that is again a little bit of a tricky problem. should say my PGs are very sincere with me. They will come and tell because we are going to attempt and do, but they will not tell the patient. Then the problem is when I am just doing it, I'll say take one more appointment, half the instrument has come, the other half I'm going to, the patient picks up my conversation, and then after that they will be PG and the patient will be there in front of my room because the patient will be yelling at the PG. They refuse to tell because of fear. But whether whatever is it, you will have to inform. There are some situations where during my consulting days, I did break an instrument that was also a hand instrument, which was totally, I didn't expect anything. I just said, oh, that's it. That was my reaction, but I continued with the treatment. And then once I finished the treatment, I just informed the patient. It was a small issue. I just broke an instrument. I'll take care of it. You just guess what the patient told me. The patient just told me, Doc, I was watching you. I watched your reaction. He just excused me. He said, because you are truthful, I do excuse you for that. But anyway, take care of that and tell me what to do, what you're going to do after that. So you're just going to inform. I don't know how you're going to inform. That depends on your skill. I'm not revealing much. Okay, here. Okay. If you want to ask me how I deal, you better come separate. I'll tell. I just have some prepared lines there, so I'm just going to tell them what's that. Of course, I will. I own up the responsibility. I tell the patient something goes wrong. Yeah, I'm responsible for it. That solves the problem. Majority of the time, and they do. Some of the patients are really understanding, even though you have other half who are not understanding, they are really understanding. Okay, so the other problem for you are going to ask is what's going to happen to the treatment. Of course, studies and literature are indicating that if you're going to bypass the instrument, clean shape all the canals, the chances that the tooth is going to survive is better. Okay, if it is going to be a periapical lesion, the chances are lesser, but this success rate is almost there for even your routine cases. Okay, so probably the best way to put it like this. Okay, at what stage of cleaning and shaping you broke the instrument is only going to determine whether it will fail. It will fail. If it is a heavily infected case and during my first instrument itself I broken during the initial phase, obviously the case is going to fail. So it's not that you can't quote that instrument and this one and say, yeah, no, it's not going to fail, it's not going to fail. So we have to take care, we have to prevent the instrument separation, or if there is an instrument separation, at least some of those simple cases, how do you manage? Okay, so before going into that, just a little bit about how the instrument fractures inside. One, either it can be, of course, there is some arrows which are pointing out. Of course, you can notice from here what I am trying to figure out, that there is a thinness of the root canal and the instrument is just locked inside. Okay, so if the instrument is just caught inside the root canal, but the motor is trying to rotate, what happens? The tip is bound, whereas the motor continues to rotate the cervical part of the coronal part of the instrument, and hence it breaks. That's a torsional failure. Okay, you can have a torsional failure. Okay, because some of the instructions what I am going to give for prevention of failure, you need to just understand this. Okay, we just ask the PG to make a video. You can see I'll just ask them to hold the tip, whereas the other part, the motor is trying to rotate the file, and then after some time, of course, it just resisting, and then after some time it will definitely break. Okay, and then the other fatigue is this one. In a curved canal, inside of the file there is tension, and outside there is a stretching, and inside there is compression. And because of repeated stresses inside and outside, the instrument breaks. These are the two reasons, or some of the researchers feel it is both a cyclic fatigue and also torsional fatigue combined together also can occur. Okay, so outside there is stretching, and on the inside there is more of a tension. And repeated stressing like this, it leads to a failure. Okay, so there are lot of other kits are there. Whatever, all these kits are very, very expensive. Probably probably what you can do, I'll just explain in some of these cases what I am going to show. Okay, one such technique, they ask you to remove the tip of your gauge Glidden drill and then enlarge the root canal. Okay, so if this is the broken instrument and it is just flush with the dentine like that, I take this gauge Glidden tip and then I just run around the broken instrument so that about 2 mm of the instrument is exposed, and then I will just use the ultrasonic tip to vibrate and take it out. Okay, that is called as the staging platform. Okay, fine. Or you do have some kits wherein you just go grasp and remove it, just for completion sake, so I'm not going to dwell too much on it. Of course, you have plenty of kits which are available in the market. Each of them are more than 50,000 or 60,000. Many times you don't get it also. The older ones, master and kit, we don't get it, but the more famous ones are the Teruchi ones which you are getting nowadays. Of course, one cost-effective management is you can get something of this U files. The U files are not less than 500 rupees. They are also sized like 15 to 40, and then you have an adapter. That adapter is also not more than 500 rupees. So you can use these U files. These are also available. You can, some of those cases which are loosely wedged, it can be probably removed with the U files or the and the adapter. Another way to overcome the problem is, I hope the dealers are not there, don't buy the entire kit. You do go in for the refills. Probably these are the tips which are available with the Teruchi tips. They each one are about 3.5 or 4.5, so you can get those tips. You can see how thin and long and slender they are. So you can, and they also give it in for the various types of ultrasonic units what you have, both for Saclac and the woodpecker also they have. So you have to just tell them for what ultrasonic unit you are using, and then you will be able to use this. So try out with these. Probably you still can manage some of those cases. Okay, an anterior tooth. Okay, you can see a pretty long instrument which is broken. You can see the axis opening, you can see the instrument there. Maybe in some of these cases just your ultrasonic irrigation, and of course you have to widen the axis slightly, little bit, remove all the tissue with your irrigants, and then you probably pass the vibration directly onto the instrument. The instrument will jump out. In fact, this was quite a large, bigger one what was there. Okay, fine. Another one in the anterior. Okay, again removed only with your ultrasonic instrumentation. These things can be attempted even by a non-specialist. Okay, another one in canine. Okay, that's a rotary what is broken, and if you notice that the axis opening, she went in for a conservative axis, and maybe because of that, and then she started using the rotary much faster before there is any pre-enlargement, and that's why the instrument broke that. It's quite a lengthy one. So you can see, if you want to do the, you can use a H file. If the canal is larger, you can probably try to insert it between the broken instrument and the canal wall, and then try to pull it out. If the probably instrument is smaller, it can come out. If not, no. I'm sorry again, the tooth picture is not seen, but you can see the ultrasonic tip. If you are using, you can be very, very precise, and you can free the broken instrument from the root dentine. In this case, we use 3 small H files. Okay, and then we did a braiding, and then we pulled it out. If you don't have any of those specialized instruments, if it is in the anterior teeth and if it is a large canal, you can still try this. Okay, so H files definitely is there in your armamentarium. Only thing you will have to use new H files. Okay, don't use the older ones. Okay, so this is the case after removing. Okay, now we go little more of the complicated ones. Okay, you can see the broken instrument in the middle third of the root canal. Of course, definitely this one will need a microscope for working, and if at all, if you are going to attempt removal with ultrasonic, one word of caution is definitely use your block the other canals, because it's easier for some of the smaller segments to come out of one canal and go into the other canal. So make sure that you block the other canals either with a temporary stopping or a cotton pellet or probably even a Teflon tape before you attempt retrieval in multiple Another one, lower premolar, full length of the root canal, she has broken the instrument. I'll just show you the video now. Okay, that's the case, of course, with this thing. We'll just see whether I can play the video. You'll have to be, I'm just using an ultrasonic ET40 tip. Okay, you'll have to watch carefully. The vibration is passed on. Did you notice it? The instrument just jumped out. Okay, so it is possible, some of the cases it can occur like this, but only another word of precaution, apart from this thing, never attempt retrieval without rubber dam. And you can see there are also instances where we could not see where the instrument has just jumped out. Sometimes it just gets sucked out with the suction apparatus. So you can never do instrument retrieval without rubber dam. Okay, fine. Another case wherein the instrument is broken, it's slightly gone beyond also. I attempted the retrieval, but this also happens. 3/4 of the instrument came out and the other half is lodged inside. Okay, we'll just see this video also. Can I take another 5 minutes extra? Is that okay? It's already 1 hour. You're okay with it? No. Huh? Yeah. Okay. Somebody said no. Can you see the, that's the buccal canal, the instrument is there. Okay. And you can see the palatal canal also there. Okay. So this is a merging canal. Okay. So failure to understand the anatomy has resulted in the instrument breaking. So I will remove that little bit of lipping of dentine. Probably you will see it in the next this thing. You can use, I'm trying to use a U file there. Okay. Just go with this. Probably towards the end you can just see. It's slightly moving now there. And once it has just come out, you can see that bit of dentine what I've removed, you can see one large canal there. Now that's all. That's the instrument there. Okay. So it was a merging canal, and failure to understand the anatomy has resulted in the instrument getting separated there. Okay. Then the other bit also was removed. Of course, it resulted in even more complicated. Of course, in this case, I will go and use all this BTR pen. Okay. Just a little bit of this thing. It's just a small loop, 0.3, 0.5 mm. Okay, the loop can be tightened or adjusted using those knobs or the slider there. Okay, I'll just show you the little, this is the loop which is there. Okay, again it comes close to about 52,000 or 55,000. This one is quite expensive one. Each of these loops are 1,500. Many a times I'll have to clip off that small rubber at the front. Okay, to see the loop, because the loop is very thin. Okay, that's why I placed that. Quite a few of times I've even just cut off the loop or loop itself because it's so thin. Okay. I'll take a scissors, cut half of the black loop there or the O-ring, then you will be able to see the loop. With that we will just most of the time the cutting is done by me. You know why? I don't have, otherwise the PG will get a scolding if he's going to chip it off. So they leave it to me and say, if I chip it off, I break it, I don't, I just look at them once or twice, because there are some times where I cut, we have used 2, 3 for a single patient. Okay, so you can see the loop there. That's so small. We'll just bend it at 45-degree angle. And just try to, in the next case you can see the video. Okay, and then that loop can be adjusted. Okay, here I am just pulling it out, but you can put it into that slider there and you can adjust it. Okay, so you can get it to, probably you will will have the other half of the broken instrument, so we put this loop around that and then we try to identify the this thing. Okay, so here I am trying to use the loop after I have enlarged the canal. I tighten it around. Okay, I am trying to get the grip of it. Suruk podra mari da. Okay, you can see the silverish part there. Okay, there I have removed it. I'll just show you the this thing. You can see the instrument is there on the loop there. Of course, this needs a little bit of the specialist work, and this one is going beyond the apex also. So I think maybe you need to get trained before you attempt this, or better refer to a specialist. Okay, and this is one of our own study. For the past 10 years, we have been doing this, and then we also noticed that the success rate for instrument retrieval is 80%. Most often it occurs in the apical 1/3 region, mesiobuccal root canal of the lower or the upper. But if you are careful enough, you will be able to retrieve it in 80% of the time. Okay, fine. Of course, for smaller instruments, sometimes your ultrasonic vibrations will come out. But if it's a longer instrument and it is wedged or threaded tightly in the dentine, you use the loop. If not, at least try to bypass and then obturate. Clean shape all the other canals properly, and this canal you try to bypass with a smaller instrument, and then at least try to obturate, incorporating the broken instrument into the filling. It is a compromise, but at least you try to probably periodically wait and watch and see what's happening. Okay, of course, the larger thing, as it is always in medicine, they say prevention is better than cure. So how are you going to? Okay, so better if you are going to use any new rotary. Currently the market is flooded with new rotary instrument. Okay, just understand the mechanism, try to practice in an extracted teeth before you take it to the patient, and of course remember the torsional fatigue. So you just move in and move out. So in and out movement prevents that torsional this thing. Gentle apical force. They even say that it is like a lead pencil you will have to use. Okay, and then pre-enlarge the root canal with your hand instrument before you use the first rotary. Okay, so that the chances of these 90 getting bound inside the canal is lesser. Okay, so it has to be very this thing. The main, now you can understand the reason. The main reason for in and out and constant motion of the file, they even say not more than 5 seconds of the file at one position. So that prevents the taper lock, sorry, the torsional fade, this thing. Okay, and then how many times you use? How many times to use? Yeah. Now there's lot of indication. They say it's single use. Okay. Definitely, patient is not going to agree with us, but